no matter how long ago was their exam. If they come to me for the first time, I do a full exam, I dilate them, and make sure, look at the nerve, at the retina, every aspect of eye anatomy.
Mhm. Okay, thank you. I'm in agreement. I always dilate my patients.
Which
It
eye?
is so important to get a really good look back there. So our next question is for Dr. Manousis. So somebody wrote in, my doctor told me I have a very thick cataract. I am not yet ready to have surgery. Will a supplement help me? And if so, which one?
So we often get these questions, doctor, what can I do to make sure my cataracts don't progress? And in reality, it's an aging process. It's part of getting older. So we always say, keep a healthy diet, make sure you wear UV protection, abstain from smoking, take a multivitamin if you feel your diet is not sufficient in all the vitamins and minerals. And there's no reason not to do surgery if you feel it's symptomatic. But if you're not symptomatic yet, it's okay to watch it. But there's not one specific vitamin that you could take to prevent the cataract.
Mhm. And related to that question, I know that there are certain drops on the market. There's one particular drop called Can-C, and I believe it's a combination of certain antioxidants. What's been your experience with that? Have you had patients take that drop, and any changes that you've seen, or any benefits or worsening of the cataract?
So over the years, I have had patients come in, using these drops. Obviously, there's not enough clinical evidence to suggest one way or another. Some patients claim that it's been helpful. For the most part, I have not noticed any significant improvement or change or reversal of a cataract for that matter. So yes, there's not enough evidence to suggest that these drops do work in preventing progression.
Mm-hmm. Any thoughts from any of the other panelists about supplements or drops?
Well, it's one of those things where I just tell patients that everybody is going to develop glaucoma. That's something that we all, I'm sorry, everyone's going to develop a cataract. It's something that we all share. How quickly it progresses depends from one person to another. I think that Dr. Manousis, all the things that she's suggested are good lifestyle habits to have in order to try to slow it down. But we don't have enough evidence to say X works. But the great news is that we have great skill sets in being able to take out a cataract safely. And we have great technology and innovations with lenses to allow patients to have vision restored. So that's the exciting news. And so it's great to be able to have these options to help patients see when they need to see better and they're symptomatic.
So well said. And also, you mentioned, certain diet lifestyle choices. So we have a whole session, actually a whole day on day 5 of the summit, May 5th, when we're going to be talking about nutrition and lifestyle and some other things that are within your control. For example, your exercise, your hydration levels, et cetera, that can help to promote your eye health. So please tune in to that day and those talks. So our next question is also for Dr. Okeke. So I know that someone wrote in, I know that there's some hereditary component to glaucoma. Is narrow angle glaucoma hereditary?
Yes, definitely. And narrow angle glaucoma has a hereditary component. Um, there are certain populations of patients who have an increased prevalence of narrow angle glaucoma. It is more prevalent in Asian populations. It tends to be more prevalent in people who are hyperopes or people who are very farsighted because of the shape of the eye being a bit more narrow, or a bit more not elongated, but a little bit shorter. And so, yes, there's a genetic component. And so if somebody has a history of having narrow angle, it's something that you should definitely share with your family members because it's possible that they could have narrow angles and they should be specifically evaluated because of that.
Mhm. No, thank you. Thank you for that explanation. So our next question goes over to Dr. D. For wet AMD, this person is asking on behalf of a family member, how long do those eye injections need to be given? Is it indefinitely, or can people eventually stop requiring eye injections, monthly eye injections?
So this is a question that we get asked all the time because these injections are so sort of onerous to have to undergo. So I very much empathize with the caregiver or any patients that are on listening. The answer really is it depends, but my statement is always that it's likely going to be long-term. The question is whether the frequency is going to be the same. So if you're receiving an eye injection every month, that's often how we started off to treat these types of diseases, whether it be macular degeneration or any other disease where you're getting these types of injections. But then a lot of times we can actually extend the interval. And that's because we have a lot of different drugs coming out on the market, and a lot of them actually have a longer acting phase. So they actually last longer. So whenever someone asks me, is this going to be long term? I always say, well, we're trying to get you to the next med that is actually going to last longer. So, if we can get you to a situation where you're getting an injection once every 6 months or maybe even once a year, some technologies out there where that might actually be the case, then I think that that's a lot less burdensome than the every month scheduling that people have right now. So we still need to give you the medicine to control your disease because it is a blinding disease if left untreated, and we can't reverse it at the moment. So we have to really protect the retina when we can. But I always say, the treatment interval really is the thing that can change, and it can really be longer than people think, especially when they start out.
Mm-hmm. Now, when you mention newer technologies, aside from injections in the eye, are there any other therapies that are on the horizon for wet AMD?
Yes. So, there's all sorts of things that everyone is trying to do to limit these injections. One is that there's an implant-based surgery where you put in an implant into the eye, and then you fill that implant with a medicine, so the medicine kind of gets distributed into the eye kind of at all the time, and that can last for 6 months. There's other medicines which are actually injectables, but they're implant injectables that can be lasting for 9 months. That's what the early preliminary data shows for macular degeneration. And then there are other forms of something called gene therapy, which is where we change the way the retina functions, where it's actually secreting the medicine, which is kind of an interesting way of trying to solve this. And that one's a little bit more experimental, but that could be much longer than even 9 months. But that's not really out on the market yet. This is all in clinical trials. But there are things out there. And I always say, so if patients are really overburdened by these injections, well, I understand that, there is hope out there that we're going to be able to kind of have a more long-term solution to the problem.
Mm-hmm. No, we hope we hope that those therapies reach the market soon. But I guess first, as always, safety has to be established, and
Agreed.
maybe they can be used for glaucoma too at some point. Similar type of technology. What are your thoughts, Dr. Okeke, on that?
Yeah, in terms of sustained delivery medications, we now actually have our first sustained release medication in the form of Durista. It's one of our common prostaglandin analog classes of medications. In a drop form, it would be called Lumigan, but it can be inserted into the eye, and it can last typically about a year, sometimes up to 2 years. We also now have an implantable device called the iDose, and it's the same class of medicine, different compound, but it has the ability to last up to 4 years. And so we're definitely in that area where we're now evolving. So we've had some first, and there are a lot of things down the pipeline in terms of being able to have other aspects of either medicine in a contact lens, medicine in another kind of insert, multiple medicines. So it's really exciting times right now because the innovation is definitely happening.
Wow, wonderful. That's really exciting to hear, especially the contact lens option. Now, I'm going to switch gears a little bit, talking about cataracts, because we have quite a few questions about cataracts, cataract surgery, and Dr. Manousis is the best person to answer these questions because she's always up on the latest technology and innovations. So first of all, someone asked, are there any specific considerations for cataract surgery with other eye diseases, whether it be pathologic myopia or glaucoma or macular degeneration? So I'll start with you, Dr. Manousis, get your thoughts, and then maybe we'll ask our other doctors as well.
It's a great question. So anytime someone comes to me and there's something else going on, either they already have glaucoma, or there's a suspicion for glaucoma, or they have any sort of retinal disease like macular degeneration or myopic degeneration, it's always important to make sure that that disease process is stable and well controlled before you proceed to cataract surgery. Cataract surgery is an elective procedure. It's not urgent. It's not emergent. So I would always refer to my colleagues, send the patient to a glaucoma specialist to make sure that their glaucoma is well controlled and nothing else really needs to be done. Similarly with macular degeneration, making sure that they don't need injections, that nothing else needs to be done. And patients with really, really high pathologic myopia, getting a good peripheral retinal exam to make sure there's no retinal breaks or tears that need to be lasered prior to cataract surgery. And if everything is well, then we can proceed.
Mhm. Got it. Okay. So you work collaboratively to make sure the patient is healthy enough, their eye is healthy enough before you do any kind of surgery. Does the surgery change the outcome of either glaucoma or macular degeneration?
With glaucoma, for example, we all know that once the cataract comes out, the pressure can be lower just from removing the lens and creating more space in the eye. So for some patients, those few points make a big difference by just removing the lens. As far as macular degeneration, the vision will really depend on what the retina is capable of. So the patients do get more light, they get more vision if cataract is visually significant. But eventually the vision will depend on the retinal function.
Mhm. Would any of our other panelists like to add their thoughts to that question?
Yeah, well, when it comes to cataracts, I agree in terms of making sure that the back of the eye is healthy and that things are not stable in the retina. If I do feel concerned about that, I'll refer to my retina specialist to get their clearance for the patient. When it comes to glaucoma, in terms of whether or not glaucoma is stable or not stable, it does provide an opportunity in cataract surgery to combine with other procedures. So we have now what we call minimally invasive glaucoma surgery, and this is something I've been involved in over the last decade plus in terms of being able to do other things to help to lower the eye pressure. So with minimally invasive glaucoma surgery, we're focused on the outflow system, and imagine in the eye there's a drainage system that typically gets clogged in glaucoma, and what we can do is we can actually remove some of the clogged material. We can flush out the drainage system. We also have small stents that can be placed in the drainage system in order to keep it open to help with flow. These things can often help to either control glaucoma or help to reduce the number of medications that patients are using for their glaucoma to have a better lifestyle and a better control of their glaucoma management. So that's a great opportunity for someone who has glaucoma and cataracts to have improved vision and also a decrease in the drop load.
Absolutely. Dr. D, do you have any thoughts about what happens to macular degeneration after having cataract surgery? Is there any effect at all or any impact?
So there hasn't been shown to be an impact, except for the fact that to what we're describing right here, I think a collaborative approach is important. I think this is a really good point to make because a lot of times I'll get a referral for cataracts from somebody who has cataracts that didn't know that they actually had macular degeneration. It was picked up by the cataract specialist. Often Dr. Manousis will pick it up. And so, we are the first ones to kind of diagnose it at their cataract eval, and then we have to actually treat them. To the question about whether it increases or changes the risk for macular degeneration, we actually have had studies on this, and the major trials that showed that vitamins helped with macular degeneration or what have you, they did not show an increased risk of progression from the dry to the wet form. And the wet form is the one that we often think about when you need injections. That did not increase with cataract surgery. So if you can get a collaborative approach and we can say and deem the back of the eye safe or safe for cataract surgery or what have you, then you can go for it. But it's important to have that exam.
Absolutely. So going back to you, Dr. Manousis, we have a lot of questions about quote unquote premium cataract surgery. So many questions, how do I know if I'm a candidate for a premium lens? Do I absolutely need to have the laser part of it? Is it safe for people over 74? So I'll let you just start with those questions. And then there's a bunch more also that I'm going to be asking you.
So typically, we start with a thorough exam. We do a thorough exam, we'll check the pressure, look at the lens, refract the patient to figure out what they could see if they got new glasses, and sort of look at every single pathology there is, if there is anything else outside of a cataract. And then we have a discussion about hobbies and everyday needs. So it's the health of the eye. Is your eye healthy outside of the cataract? In terms of you having one lens or the other, and what are your hobbies? So I will typically sit next to the patient and I'll ask them, what do you do in your everyday life? What do you like to do now? What would you like to do 10 years from now? What are the 3 things that you do every day where you feel that you're not seeing as well as you would like? Where would you wish you saw better? What elements of your vision are important to you? Is it important to you to see distance? Is it important for you to see near? Do you like to wear glasses? Do you want to get rid of glasses or reduce your dependence on glasses? And the answers can vary. You know, some people come in and they say, you know what, I love my glasses. I like the way they look. They hide my wrinkles. You know, I can't imagine myself without glasses. No, I do not want any type of premium or multifocal lens implant. So this discussion can go one way or another depending on what the patient needs or wants. But globally, there's two sets of lenses that one can have. One set is called a monofocal or single vision lens, which provides great quality of vision, but only at one spot, which means distance, intermediate, or near. And we typically could put that lens in any eye, an eye with macular degeneration or glaucoma or any other type of pathology. And then there is a group of lenses that provide you more freedom from glasses. And they are multifocal lenses or extended depth of focus lenses. There's a lot of companies that make these lenses, and they all do different things. They're all meant to give you some distance vision and some near vision, depending on the lens. And which lens will go in your eye depends on your hobbies, on your everyday needs, and your eye health. So multifocal lenses typically do go into a healthy eye, meaning no macular degeneration, no loss of central vision. Some of these lenses, especially extended depth of focus lenses, you can put in an eye that has early or mild glaucoma, but we do try to put these into a healthy eye. So that's sort of a summary in a nutshell. A 2-minute summary.
What about the age question? Like, is there a particular age after which or before which a person may be better suited to this type of premium surgery or premium lens? And then next is also the laser question, like, is laser required for these lenses?
Thank you, Rani. So no, the age doesn't really matter anymore. You know, we have very healthy 95-year-olds, you know, who go for multifocal lenses and they tell me, you know, if I finally could take my glasses off and, you know, I'd like to read without glasses and so on. So age is irrelevant, really. You can have, you know, as long as your eye is healthy, you can have any type of a lens you want. Laser-assisted cataract surgery. You know, you don't have to have laser-assisted cataract surgery. Patients often ask, doctor, do I have to have laser-assisted surgery? And the answer is no. We want to have safe surgery, right? We want to have efficient and safe surgery. And so the physician that you go to, whatever technique they use, we want to make sure that it's safe. And in certain conditions, laser-assisted surgery makes it maybe a little safer. Like, for example, eyes that are very small or crowded, or cataracts that are very mature. The laser can help fragment the lens and reduce the energy we use in the eye to break up that cataract. So in certain situations, I could suggest to a patient that laser may be a better choice, but it's not a prerequisite.
Got it. Would either of you like to add anything to that?
Yeah, I mean, in terms of, from my standpoint, in terms of glaucoma, I do cataract surgery on glaucoma patients mainly, but also just straight cataract surgery, and also use laser technology and advanced technology lenses. It is true, like maybe, you know, some years ago, one would say, okay, if you have glaucoma, you're not a candidate for any of those kinds of lenses. But now with some of the technologies and the changes and the innovations that are being made, glaucoma patients can be, and as Dr. Menounos said, in patients who have either suspects or they have mild glaucoma, or sometimes people can have moderate glaucoma, but they don't have a lot of visual field loss. It's still on the milder side. Then they can be a candidate for lenses, especially the extended depth of focus lens has allowed for there to be more range for those patients to have. But if a patient has, let's say, glaucoma suspicion, it's so mild that they have no visual field loss at all, they could be a candidate for the advanced technology lenses, even the trifocal lenses that we have down in place in a number of patients. So there are options, but as Dr. Menounos said, it takes a very thorough exam of the front of the eye, the middle of the eye, the back of the eye, to make sure that there isn't a lot of pathology. For example, if someone has a lot of dry eye issues in addition to glaucoma, there might be too much going on, or maybe their glaucoma is not controlled enough and they're still going to be on a lot of medications, and that's going to affect their ocular surface. They may not be the best candidate. So there is a need for thorough examination, but it's good to know that there can be options, but one just has to see how they look in the exam room.
Oh, thank you. Thank you for that explanation. Dr. D, what if a patient had early AMD? So just a few changes in the back of the eye, a few drusen, no family history. Would you advise that that patient have a multifocal or enhanced depth of focus lens, or just stick with the standard lens? What would you suggest?
So it sort of depends on where the lesion is. So if the lesion, I think, is visually significant, so it's right under the center part of the retina, which is called the fovea. So it's not just the macula, but the center part of the macula, so the fovea. Then that might be an issue. And one of the reasons why we sort of counsel against having some of these premium lenses in that setting is because of the expectations that the patient would have. It's not that they wouldn't benefit from cataract surgery, but it's that their expectation may be that they're going to have this, very premium view, afterwards, and they're going to be able to see near and far and all this stuff. And then all of a sudden they feel, well, no, it's not really what I thought it would be. And that's all because of their retina and has nothing to do with the cataract surgeon. And the cataract surgeon could have done a fantastic job and a phenomenal lens could have been chosen. So, it's one of those things where, again, back to your first question that you kind of started with me, which was, is a dilated exam important? The answer is yes, because even in these cases, we really need to know specifically where the disease is located in the retina. But if it's very numerous and, there's even a bias that, I think that it's not going to really benefit them, then I will actually sort of vote, as I say, for a monofocal lens.
Okay. Going back to Dr. Manousis, we have a couple of questions in the chat about patients who've already had refractive surgeries, such as LASIK or I think somebody had asked about PRK. Do you have any special considerations for these patients when you do their cataract surgeries? Any special recommendations about what type of lens implants to put in after these refractive procedures?
So, now we see a lot of patients who've had laser vision correction because they've had it in the early 2000s and now they're coming in for their cataract surgery. So as many know, in laser vision correction, we change the shape of the cornea permanently. So we either make it steeper or flatter, and that changes the type of measurements that we do to figure out which lens implant will go into the eye. And it can make it a little bit more challenging to do those calculations. We do have new formulas now that allow us to be a little bit more precise with them. But that's one of the considerations. And if someone wanted a premium lens, let's say a multifocal lens after they've had laser vision correction, one of the considerations is that if the cornea is altered significantly, it's made too steep or too flat, the quality of vision may not be great after a multifocal lens implant in someone who's had laser vision correction. So it really depends on what the cornea looks like and how it's been altered by laser vision correction. Sometimes for these patients, I would recommend a single vision monofocal lens for better quality of vision. We also have great technology now to help us figure out which lens implant and confirm it on a table. It's called Optiwave Refractive Analysis, or ORA, which can be done at the time of cataract surgery when the patient is on a table, to double check those measurements and make sure you're right on target. In addition, we have new lenses on the market. They're called light adjustable lenses. And that's the only lens on the market that can be sort of fine-tuned and adjusted after it's been placed in the eye. So because the margin of error is a little bit higher in someone who's had laser vision correction in terms of the type of lens that goes in the eye and where you end up refractively after the surgery, this lens really nails it for someone who really wants to be right on target and seeing perfectly at distance or perfectly at near, because you could sort of fine-tune it after the surgery.
Yeah, so what I'm hearing from you both is it's really important to have a very detailed discussion with your surgeon about what your needs are and what your expectations are before making that final choice.
Exactly.
Yeah. So Dr. Manousis, we also had somebody ask about they had a lens put in, but they're not quite happy with that. It seems like the lens may have rotated, so their vision's not as good as it once was. What can be done about that type of situation where the lens may be turning within the eye after it's put in?
So typically we talk about rotation when we talk about astigmatism correcting lens. They're called also toric lenses. We have to do exact measurements and orient the lens within your eye, specific on those measurements, specific to your eye. And sometimes, especially in patients who have larger eyes or high myopes, there's a little bit more propensity for that lens to rotate. If we do notice that very early on, like in the immediate postoperative period, you can go back and put the lens back in place.
Mhm.
in the hopes that it'll just stay there and won't rotate anymore. Obviously, if it's been some time, and these lenses tend not to rotate after a couple of weeks, they tend to sort of scar in place. But if there's been a change in the prescription and there's blurry vision that may not be correctable with glasses, or the patient just doesn't want to wear glasses, you can consider laser vision correction to treat the cornea and reduce that prescription, and reduce either farsightedness, nearsightedness, or astigmatism.
Mhm. What about if someone's really unhappy with their lens, taking it out and putting in a new one? Is that a possibility for some patients?
So there's definitely a possibility of exchanging a lens. A lot depends on the anatomy, a lot depends on what kind of a lens and how long it's been there. These lenses do tend to scar in place. So after many, many years, especially if the back of the lens has been cleaned with the laser, it may be a little bit more challenging to get the lens out safely. But it all depends on what we see during the exam.
Okay, understood. Dr. Okeke, we have a question in the chat about, you mentioned earlier about home monitoring of eye pressure. Are these devices reliable? What's been your experience with them?
My experience with them has been mixed. I do think that they are available and they can be reliable. But the training needs to be very robust in order to make sure that happens. And so these are great opportunities to be able to measure the eye pressure at home and then bring that information to the doctor. But there does need to be an extensive training so that the information.
Sorry, Dr. Okeke, your audio is very, very, it sounds very muffled or far away.
Is this any better?
That's much better. Yes, thank you.
I apologize. What I was saying was that my view of the home-based tonometries are mixed picture. I do think that they can be very effective, but it is determined based on the fact that one has to be educated very well in order to do it properly. There are sometimes challenges that a patient might have to be able to do it properly. And so one has to be able to get education and then kind of a showing that they can do it properly to make one feel comfortable with them being able to do it at home. But if those parameters are met, I do think that it is something that can be a very great asset to the patient and also the doctor.
Yeah, you're absolutely right. I mean, just having more data is not always a good thing. It really needs to be good quality data, and have a purpose. You know, how is it going to change the management of the patient? So it's not for everyone. That's what I'm hearing from you also. So, Dr. Deobakta, I have a question here about, I'm sure this comes up all the time. A patient has early macular degeneration. And they want to take a supplement, but they're told that AREDS 2 may not be the appropriate supplement for them. What do you usually tell them?
Well, it sort of depends on what they mean when they say that. Some people, it's because so the ARED supplements are basically the very basic vitamins that we have, but in different doses. There's vitamin C, vitamin E, there's zinc, there's copper, there's lutein, there's zeaxanthin, there's these things that you often have heard of that you can even take separately over the counter. But most of the time, the reason why someone has an issue with it is because of the zinc. And generally speaking, the reason why is because the dose of zinc in the AREDS 2 formulation is something like 8 to 10x what the average dose would be for an average adult. And the reason that's the case is because it was shown that actually could reduce progression from dry to wet in the big studies that we did decades ago. But the problem is that zinc can cause problems with the stomach. It can cause problems with copper absorption, which is the entire reason why copper is in the actual pill itself. And it can cause a whole host of other things. It can cause urinary problems, kidney problems. So a lot of times patients will ask, I can't kind of tolerate that. I may have kidney disease, or I may have other issues, or my stomach hurts. So I don't want to, is there some other way to do something about this? The first thing I always say is, yes, you can. Any amount of vitamins is actually helpful. There are zinc removed doses of the AREDS 2 formulation that exist. And I often will just print that out and show patients that you can get that either online or at some pharmacies. And And then also, if a patient's like, I can't take vitamin E or what have you, you can really just take lutein and zeaxanthin if you're early enough. And we grade macular degeneration based on a dilated exam, and we take a lot of photos like OCT and fundus photography and autofluorescence, and we make sure to determine whether someone's in what stage. So if you're in the intermediate stage, which means that you have a lot of the drusen, and for those that know, there's a certain sizing and a certain amount, then I really kind of do push the other vitamins that are part of the original AREDS2 formulation. But if you have early macular degeneration where you have sort of sparse drusen, or it's just a little bit less widespread, that it doesn't qualify as intermediate, then I often will say, well, it's okay to just take the lutein and zeaxanthin. So I would say these are the types of ways you do it, but if you can take the AREDS2, you should.
For even the early patients.
Oh, and so the question is for even the early patients, it's reasonable to do that. So I often say, because I have seen a lot of issues with patients when they progress, because macular degeneration is a progressive disease. It doesn't reverse. It's an age-related process. There are things you can stop, like smoking, which is a huge risk factor. But even if you stop smoking, it can progress. And so you want to do everything you can to kind of prevent its progression. However, if a patient says, I really can't do that, then we kind of go down that tree. And especially if you have a family history. So if you have a family history of macular degeneration, then that's another point in favor of kind of starting early, even if the data said that it really is only for intermediate macular degeneration patients. An early patient has been shown to have a trended benefit if you look at the studies. So I often say, take it if you can.
Mm-hmm. Okay. I'm gonna play a little bit of devil's advocate here with you, Dr. D. So in the AREDS studies, the AREDS2 studies, there was actually one smaller arm of patients who got the normal dose of zinc, which was 25 milligrams. And they did just as well. They had the same rates of progression, or reduced rates of progression, as the group that got the higher dose, which is 80 milligrams. And according to the US recommended daily allowance, the highest limit is 40 milligrams. So the amount in AREDS is double what the US RDA says is safe. So what would you say to that? Why is it that the AREDS2 formulation has that super high dose when we know that a low dose works just as well? Any thoughts?
I mean, I would say that there are cohorts where that's the case, and then we see patients that actually do progress, right? Not all patients did, even if you are taking the vitamin, you can progress. I mean, it makes a nice sort of reduction in relative risk, but it's not a holistic relative reduction. What I would say to you is that the vast majority of what's out there on the market is 80 is this higher dose of zinc. And so what I find in practice is that if I say that zinc is something you should avoid, then patients don't take the vitamin at all. And then you kind of run into these problems where it's sort of like pragmatically it's difficult. But I'm actually not opposed to a lower dose of zinc if that were readily available. So I think that that's okay. But if you're gonna choose between not taking anything at all and then taking the lower dose 25 or even 40, I don't think I've seen a 40, but 25 milligrams of zinc, then that's totally doable for me. I think that's fine.
Mm-hmm. Yeah, and there is a very small study that showed that in terms of genetics, there are some genetic variants that may increase your risk of progression if you take a high dose of zinc. So I think that's still very controversial. And I think someone had asked about that, and we will discuss that on day 5's live Q&A. So hold that thought, whoever asked that question. Okay, we're just about nearing the end of our live Q&A, and I want to respect everyone's time, especially our panelists. I know it's Friday evening; they probably have other plans, but I'll just go around and ask each of you, are there any last thoughts you'd like to leave our audience with about each of your respective areas of expertise?
I say just get regular eye checkups. Don't forget about your eyes. Find an ophthalmologist that you like and that you trust, and go get your eyes checked.
Excellent. Yeah, and actually, I think the recommendation is the American Academy of Ophthalmology recommends everyone above the age of 40 should be getting an annual dilated eye exam. So if you haven't yet, call, make your appointment next week.
Dr. D, I'm coming to see you.
No problem. Hey,
By the way, they work in the same office, so
yes, that's right. I would say that what's really important to always remember is that to Dr. Manus's point that we need to always be checked. But the thing is, a lot of these diseases, they're progressive, so I always say, it's like it's not just one check sometimes, and don't feel down that if you have to see the eye doctor, it's actually a pleasant experience, I think, if you see Dr. Manus's or Dr. Okeke, I hopefully with me too, and Dr. Banik, but you just really, don't get down if you have to see the doctor a few times, because it is very important and we can really prevent a lot of things that can hurt you in the long run.
Yeah. And actually, one of the themes of our summit is an ounce of prevention is worth a pound of cure. And that speaks to both of your comments. Dr. Okeke, any last thoughts?
Yes, and I would just applaud of all of you for being here, because an educated patient is the best patient, and I know that knowledge is power. And when you educate yourself, you can help yourself to be the best advocate for your eyes. And on that note, I did want to just put a plug in for my book, the Glaucoma Guidebook. I wrote this with my patients in mind. I know that I can't always educate my patients to the level I'd like to in the clinic. So I poured it out into this book, and I just invite you to take a look at it. If you have glaucoma or you know someone who has glaucoma, I wrote it to be empowering, and I also wrote it to be encouraging. There are stories of other glaucoma patients within this book. There's real world advice from 20 years of practicing glaucoma. And there's lots of pictures, lots of analogies to try to simplify glaucoma in a way that you can understand, feel encouraged, be able to communicate with your doctor easily so that you can know what's going on and be your best advocate. So it's called the Glaucoma Guidebook at theglaucomaguidebook.com. And I just have my audiobook coming out soon for those who may be visually impaired. So I invite you and take a look. And thanks for your time. Thanks for being here.
Thank you, Dr. Okeke. And we actually have, if you go into your course portal, we have all the links to Dr. Okeke's book as well as the audiobook. And she has some free downloads that you should also take advantage of. One is on eye drops. So I highly recommend that you check them out and take a look. And so with that, I want to thank all of our panelists for spending some time with us today on the live session for the Eye Health Summit. It's really been eye-opening to hear about your insights. And again, I'm so appreciative of your time, especially on the beginning of a weekend to spend time with us. So thank you all. So I will unmute everyone so you can all express your gratitude as well. So let me see here, or you can put it into the chat. You could do that as well.
Thank you very much.
Thank you so much.
Thank you very much.
Very much.
Thank you.
Appreciate
Thank
it.
you.
Thanks.
Great information.
But that only works for a certain period, because at the end of the day,
Thank you.
thank you. I got my questions
Thank
answered.
you to all.
Like better than anyone else.
Thank you for being here. So I will let our
Bringing
panelists
the numbers
hop
as
off
being
if
the
you need to
temporary
go. But
equivalent
for the rest of
of
you,
just
please
the
stay
health,
because
that
I'm just
doesn't
going to
happen
do
very,
some
very soon.
announcements and
I think
get you
many
ready
people,
for what's
even
to come in
within
the
the
iHealth
face of
Summit.
the party,
So
will wonder
please stay on.
what
Thank
are
you
we
all.
doing
Thank you,
and why isn't
Dr.
this
T, Dr.
working
Manusas,
yet?
Dr.
So I think we'll
Okeke.
see
Have a
more about
wonderful
this kind of
weekend.
be patient talk from the administration.
Okay,
I guess, also
um,
watching polls. On the one hand, we
I think I'm unmuted. No? Okay. All right, everyone. Well, thank you again for joining us on day 2. I'd love to get your feedback. I know yesterday some people had a little bit of delay in getting into the portal, but we actually now have 2 ways that you can access the content. One is you can go into the portal, watch all the talks as part of the free summit. And then if you're in the VIP, the Visionary VIP, you also get access to the master classes and a lot more bonuses. So if you haven't upgraded yet, I would strongly suggest you consider doing that. We just had our day 2 masterclass today, which was talking about all of these concepts, the the topics that our experts talked about. So again, presbyopia, cataracts, cataract surgery, glaucoma, macular degeneration, and age-related changes. Please check out that day 2 masterclass if you haven't yet, and upgrade if you haven't yet. So the second way to access all of the information is we made it a little bit more streamlined. So we have an event dashboard, and I will put it into the chat. Let me just see here if I could do this here. The event dashboard is your go-to, like you will see the schedule. You can access, one second, I have to grab the link. Sorry, give me one moment. You can access all the interviews, and so you can see what's coming up next. So, so it's a great, simple way to access a lot of the talks. And just as a reminder, because of the delays yesterday with people, not yet having their password to get into the portal, we are extending the access to the day 1 talks for the free summit until tomorrow morning at 9 a.m. So you will have until tomorrow morning at 9 a.m. to watch both day 1 talks, all of the day 1 talks, the day 1 masterclass, the day 1 live Q&A replay, as well as all of the day 2 talks. And I will have this video of the Q&A session uploaded into there as well. And then tomorrow at 9 a.m. Eastern, day 3's talks will go live. So then you'll lose access unless you're a VIP. If you're a VIP, you have unlimited access. And then there were also some questions about timing. So we are releasing each day's talks at 9 a.m. Eastern, but it does not mean that you have to watch them at 9 a.m. Eastern or wherever it is in your time zone, wherever your corresponding time zone is. They are available at 9 a.m., but you can watch them at your own pace. So again, I'm not asking people to wake up at 5 a.m. to be ready to watch the talks at 6 a.m. if you're, for example, if you're on the West Coast, but they are available. You have 24 hours to watch them. So take your time, watch them. And again, hopefully you join us in the VIP session. I would like to ask if anyone has any questions, please raise your hand and then I can unmute you so you can ask your questions. I don't see any hands raised. Let's see. No questions today. Okay. Are you sure? Nothing that Okay, so Donna is asking, how do I find the Q&A on the portal? So these recordings of our live sessions, if you go to your portal, there is a navigation bar at the top where it says the day, and then it says, I believe there's forum, where it's a community forum where you can put your comments, questions, etc. But there should also be a replay tab on there. So if you go to the replay tab, you can find yesterday's Q&A session, and then later on today, we will add today's Q&A session in there as well. So hopefully you can access that. Okay, so now I'm going to, Janice, I'm going to unmute you, and please go ahead and ask your question, Janice.
Yeah, actually, it was more a question I wrote in, and it's what I was wondering, because I didn't exactly cover it. I have narrow angles, and I just had a bad fall, and the fall was I hit my head, and unfortunately more on the right side, and I had a prior fall. So what's happened is I believe they're definitely the cataracts in my right eye is getting harder to see, and they're rapidly progressing. The left eye is a little bit better, but I can see, and I've had a lot of stress. So so I've had narrow angles, then this. There's something else where I can see, which is really weird. Sometimes it's like double vision, or the eyes are not working together. It's almost like they got 2 separate things going on here. And I can't see, my ophthalmologist has given me a referral to a guy that does surgery, but not till August. So yeah, I am looking at supplements, but I'm also looking at, do they have to deal with it? The thing is, what she told me is if you have narrow angles and you are given, I don't know what you call it. You know what I mean? Like they put the drops in your eyes, that you could actually get, I think it's glaucoma. So therefore she didn't even want to put in the dilation groups. So it's kind of like I see all these roadblocks, You know what I mean? Because if you're, and should the surgeon actually deal with the narrow angles first, and then at that point, then consider cataract surgery. You know what I mean?
So first of all, unfortunately, I cannot give you any personal medical advice. This
An
is
impression is good. An impression is fine. I'm not holding you to it.
yeah, like I'm not able to. So I can't really give you, and I've never examined you before, so I can't give you any personal advice. What I would say is, if there are multiple issues going on, just as our panelists were alluding to, eye care is a team effort. And so I would say you have hopefully your primary ophthalmologist, but maybe get a second opinion from a glaucoma specialist about how to manage the narrow angle. And, of course, they can give their input about cataracts as well. And then if you are having doubling of vision or ghosting of vision, that absolutely needs to be addressed. Is it because of the cataract? Is it because of the trauma that you had? There are a couple of different possibilities. So if your general ophthalmologist is not able to figure out why you have double vision, then you really do need to go see a specialist, and the specialist would be a neuro-ophthalmologist. So that's what I would say.
Okay, one last question is with an MRI. I'm booked with an MRI.
I'm sorry, again, I'm
you
going to
can't.
have to cut you off.
Okay, no, I
because
just want to ask you in
you
general,
really
just in general, is an MRI overall, forget me, is an MRI in general, like okay for the eyes? If one, not me, has an eye disturbance, can an MRI?
Absolutely. We have pregnant women do MRIs. We have newborns do MRIs. It is very safe. As long as you don't have metal in your body. That's the limitation. They will ask you before that. So, all right, Susan,
Oh.
we're going to move on to you. So, Susan, I just unmuted you, so feel free to ask your question. Susan, are you there? Okay, I don't know what happened to Susan. I thought I had unmuted her, but maybe she hopped off the call. I'm not sure. Okay, we're going to move on, Susan. So if you join us again, then please raise your hand again. So I'm going to move on to Francis Weller. So Francis, go ahead and ask your question.
Do you have any patients, or are you familiar with MCAS, mast cell activation syndrome?
Yes.
And how do they respond generally to drops in their eyes?
So mast cell activation syndrome is an immunologic issue, and people they can be very sensitive to many things, including food, medications, including foods, environmental exposures. So I think the best thing, what I typically do, and I do practice functional medicine, so I'm very familiar with MCAS, is I typically recommend preservative-free drops and then see how they do with those. And, there may be a reaction, there may not be a reaction, but you want to take the preservatives out of the equation because a lot of drops will have preservatives. And sometimes what I also do is, there are drops available. Let's say a patient has glaucoma and they need to be prescribed glaucoma drops. If they have a sensitivity, if they have a predisposition to certain sensitivities, then I recommend that they get compounded drops. So oftentimes I'll work with a compounding pharmacy to get them compounded drops, which oftentimes they do better with.
Okay, and one other quick question. Do you see patients that have mycotoxin issues, like mold issues, that have been exposed to black mold that are affecting the eyes?
Yes, I have. I certainly have. There are various different ocular manifestations of mold toxicity.
Thank you so much.
You're welcome. Okay, so next we have Nina. I'm going to unmute you. So go ahead and ask your question. Hi again, Nina. Nice to see you.
Hi. Thank you so much. And I think that Dr. Manusa did address the question about, changing cataract lenses. And I told you that I have to wear driving glasses because of the replacement. But I do have the pinhole idea. These are the glasses that they're talking about. They have pinholes everywhere. But I was diagnosed with Addie's pupil, and I had experienced the use of pilocarpine drops, and it is correct. It does does, give you a lot better. It closed the Addis pupil, which was always dilated.
Mhm.
And so once I did that, eventually that corrected the situation. So I wanted to kind of share that. And I guess they don't use it now, but they're discovering it, and I think that's exciting to do, because when I did use the drops, it was really really clear to be able to see that.
That's great. Pilocarpin's been around a long time. We know it's very safe. We've used it for glaucoma for decades and decades and decades. It's probably one of the original glaucoma drops. And yes, I do use it sometimes for my patients with 80s tonic pupil. You can use it long term. It's very safe. Just one word about the pinhole glasses. I am not a fan at all of pinhole
Yeah,
glasses.
right,
At all.
right.
I mean, if you think about it, it's making your entire field of vision very dark. And
Correct.
especially if you're driving with it at night.
Oh, no, I don't use it for
no.
driving. It's just
Yeah.
for watching television.
Yeah,
or
in
like
certain
that.
situations, especially if it's really bright out, yeah, it can help you, absolutely. But
Right.
if the lighting is dim, it's probably not the best option.
No,
So
right.
thank you, Nina.
I
Thank you for
appreciate it.
joining
Thank you
us.
so much.
So Victoria, you are up next. So I'm going to unmute you and hopefully, oh, here we go. For some reason, it's not unmuting. I'm not
That's
sure.
my question about the cataract lenses.
Again, Victoria, I'm not sure why I'm not able to unmute you. Maybe you need to check your Zoom settings. So I'm going to come back to you, but Susan G. I'm going to unmute you. Okay, Susan, go ahead.
Thank you. I'm getting it. So my question is about the portal, because today I've been watching day two, and I'm on the VIP. And so I've been downloading the transcripts, and for some reason with Dr. D, I wasn't able to. I clicked done, and then I can't find the place to download the transcript. Did I do something wrong, or is there
I
some
wasn't
other
aware
way?
of there being an issue. No one else has written in about that, but I will have my team check it. Now, sometimes, were you able to download anything? Did your computer?
Yes, yeah, I downloaded yesterday, and I downloaded the other ones today that I listened to the first three, I think. The first two or
I'll
three.
check on that, because usually they're simple PDF files, and they're not long. They're mainly just
Right. And it was, there's a button where it says download, and it isn't there anymore after I clicked the done.
Could you
And
do me a favor, Susan? Could you
Mhm.
please email support@drranibanik.com? Just let us know that you had an issue with that particular
particular
transcript,
one. Okay.
and the other ones were okay, and then I'll have somebody look into that.
Okay. Thanks very much.
You're welcome.
And my husband did want to know, because he keeps saying to me, I have pinholes that I just use for looking at the computer. I don't drive or anything else with them. And he's saying, why can't you drive? Why can't you make the holes closer together so there's not the plastic around them? And why can't you make them better? And because he's
Yeah,
a
I mean, the whole
scientist who
point
likes to improve.
the whole point of pinhole. So pinhole is what we use diagnostically in the office. We don't use it therapeutically.
Right.
Never, really. I mean, because it degrades vision peripherally. So yes, you can have really clear central 20/20 vision, but your peripheral vision is not great when you're wearing pinhole glasses.
Right.
So it's not something practical for, if you're walking around, if you're out and about, if you're looking at one thing and, let's say, as Nina mentioned, like if you're just watching TV and you just want to see that one distance and
Right.
you're not really looking around, you're not walking around, you can do the pinholes, but you just see, there's a difference in the quality of your vision with the pinhole glasses and
Yeah.
without. And I'm not a big fan of them for that reason.
Right. So I'll mention the word quality, because he put them on and he said, "Oh, I can see," but we need to do a little more in
Yeah,
depth so
do it
that
at home first rather than doing it
Oh,
outside home.
right.
Do
Thank
the
you.
test at home first. Okay, great. All right, let me see here. So I think next is Karen, but I don't know where Karen went. I just saw her there. So Karen, you were up and then you disappeared on me. So I don't know where. Okay, Nicola. So Karen, again, if you hopped off and get back on, just raise your hand again. So Nicola, I'm going to unmute you. So go ahead and ask your question.
I would need to know about if you're aware or familiar with Leber's, LHOM.
It's one of my specialties. Yes.
Oh, really?
Because I'm a neuro-ophthalmologist and I've actually run clinical trials in Leber's hereditary optic neuropathy. Yes, I know a lot about it. Absolutely. I have a lot of patients with Leber's.
I'm not sure nobody can really certify that this is what I have. I lost my sight on my left eyes about 4-5 months ago, and it was progressive. And but in DNA, or for sure, it's in my sight. My brother was MLM, no, multiple sclerosis, MS. And apparently it was on this 32 years old. My aunt was 32 years old. My daughter, 32 years old, both of the eyes, Leber's. And now at my age, in my 70s, so it's like, why it would happen now? Out of the
That's a
blue.
great question, but I would say if you have a strong family history and you've lost vision centrally, meaning you can see in the periphery, but your central vision is decreased,
Only
then
one eye.
Sorry?
Only one eye. The
Yes,
left
only
one.
one eye.
Yes.
But if it's central, that's what Leber's does. So Leber's decreases central vision.
I see.
To really know would be number one, get an eye exam by a neuro-ophthalmologist.
Yes.
And
Yes.
number two, do the genetic testing.
Oh,
Probably,
I see.
yeah, you probably have, the gene, but if you absolutely want to know, I don't know if your daughters have been tested, but you do the genetic testing. And
Okay.
there are some we're just about to start a new clinical trial for Leber's, probably, I'm guessing in the fall. And I don't know where you are, but you may want to reach out and see if the company is called GenSight. It's a gene therapy trial. So you may want to reach out to them and see if there's a center nearby you and if you may qualify.
GenSight, G like
GenSight.
John?
GenSight, GenSight. Okay.
Okay.
We're going to
I'm
move
in
on
Toronto, Canada.
Yes. So again, you can reach out to the company and see
Okay.
if you can find a center close to you. Okay, we're going to move on to Karen.
It is any cure, or it is any cure coming?
I'm sorry, we'll have to move on because there are quite a few hands still up. And
Okay.
so, yeah, we're going to move on here. Karen, go ahead.
Okay, thank you. I just want to ask if when your optic disc is so tilted and they can't check it up, can that suggest that I have changes in the nerve optic and decide that I have glaucoma?
So again, many of you are asking personal questions and I cannot answer them because you're not my patients. I don't know what your nerve looks like. And it's not just the tilting, it's also the field test and the OCT test that's important. So
Yes,
I cannot answer that question, but it's not just one metric. It's a combination of things that eye doctors look at. And so there are many patients who are born with tilted nerves. That's the vast majority of people with tilted nerves. It's not that they develop it over time. They're born with that. It's an anatomic variant. And so the best thing is to follow you out over time to see if there's a change. And if there's a change in any of the testing, then maybe your doctor may recommend a treatment, but without a change, we typically don't treat.
Okay, and can the vitamin D help for your vision? Is there any
helpful for general health? And there is some evidence that it's helpful for macular degeneration. Yes.
Okay.
We're talking more about vitamins and supplements on on day 5 of the summit. So please join us.
Okay, thank you very much.
You're welcome. Okay, Victoria, you are next. And I'm going to take 2 more and then we're going to close out today's session. So let's see. Okay, Victoria, go ahead.
Okay. If a person has macular degeneration, or not macular degeneration, but pseudo exfoliation, does it make it more difficult to remove cataracts?
Yes. Yes. It makes it very challenging in some patients, depending on how much pseudoexfoliation there is. And there sometimes are specific surgical techniques that are used or additional aspects of the surgery that are performed. I wish Dr. Okeke were here to answer this question because she would be the perfect person. But yes, it is a completely different approach when not completely, but it's different when someone has pseudoexfoliation. So yes, be sure you're seeing a glaucoma specialist.
Okay, thank
And
you.
if you're getting cataract surgery, make sure you're getting it done by a glaucoma specialist.
Okay, thank you.
You're welcome. Okay, we'll take one more. So, I believe it's Chell. I don't know if I'm pronouncing your name correctly, but I hope I am. Chell, go ahead.
It doesn't matter. I answer to anything. Can you hear me?
Yes.
Okay. I just had cataract surgery and I'm trying to decide what glasses to get. They've corrected the distance to about 100 so I can see okay, but it's blurry. And one eye is for close distance and one eye is for medium close distance. So like everything within 6 feet is really clear. So I'm trying to figure out if I should get something in the glasses for so that I could still wear them when I'm looking at close things, or if I should just get some that I just take off and only put on when I'm trying to look far away. What
Again, I cannot answer that question.
Well, I
I
mean,
don't
just
know.
what
I don't
is
know
more
what your
what
prescription is.
no,
I
no,
don't
no, just what
eye.
is more comfortable for people who have the close vision corrected, but still need the far division. Do more people like to have glasses that they take off, or is there a lens that's comfortable that you can, because like with the progressives, you always had to, I was the one that would take my glasses off to see up close because, I'm a, nearsighted was. And so I don't know if it would be the same kind of weird thing now with my close vision corrected.
It's, it's what Dr. Manousis was referring to. It's what you're most comfortable with. And the only person who'd be able to answer that question is you. So what I would say is, when you go to the doctor and they prescribe you something before they prescribe it for you, there is such a thing as trial lenses. So they put the prescription in just like a temporary lens frame, and then you walk around with it. You walk around in the office with it. You see what you feel comfortable with, and then you can try some different things. So before you actually get the glasses made, maybe
that's
do a
great.
trial in a trial frame in the office and see how you feel. That's what I would say.
That's great. That's what I need because I just don't know which is going to feel more comfortable.
Yeah, and you can just try them on before you have them put into frames that you've chosen. So it's like a temporary, a trial. So
right. Okay. Yeah, that was the exact answer to what I needed. Thanks.
Okay, great. So,
Thank you.
so I did want to, before I close out today, I wanted to let you know that again, the portal tomorrow will switch from day 1 and day 2 to day 3 only for the free summit. So be sure you're watching all the talks, last minute if you're in the free summit. If you're a VIP, no issues. And then in terms of our prizes, so yesterday we didn't get to give out any prizes because I said we were going to delay it. So just to let you know, there's still quite a few of you on the call, and I think there are more people on the live stream on YouTube. But to let you know that in June, I have a course that I give called Ageless Eyes. I've done it actually many times in the past, but this time I'm making it my signature program. So we're talking about the whole range of eye issues from usually it was focused just on dry eye and presbyopia and light sensitivity, but now I'm expanding the course to include cataracts, cataract prevention, glaucoma, macular degeneration, and really nutritional, lifestyle, and supplement approaches. And the new course is going to be called the Ageless Eyes Signature Program. It's a 4-week course. So we're giving away scholarships to the course. So our sponsors, we have a couple of sponsors. Yesterday's sponsor was Bausch & Lomb, and today's sponsor is Omni Actives. And so we're giving out some scholarships on behalf of our sponsors. So our Bausch & Lomb winner of the scholarship to the Ageless Eyes Signature Program is Hazel Thomas Ryan. So congratulations, Hazel, on winning that scholarship. It's an online program, by the way. and it's happening in June. So congratulations. And let me see if I can unmute you. Let's see. Are you there, Hazel? Hopefully you're there.
You. I'm here. Thank you.
You're very, very welcome. So congratulations to Hazel. And then we have one scholarship from our sponsor for today, day 2, Omni Actives, that they are the ones who make the lutein and the zeaxanthin, which are essential eye nutrients. And so our winner for that scholarship, again, for the same course, the Asia's Eyes program, by the way, it's valued at $597. And we're offering it during the summit for $297. We'll talk more about that later. But again, you're going to be winning a scholarship. So our winner for that scholarship is Dawn. So I believe Dawn Open, is that open? I can't quite read your last name there, but I'm going to unmute you there. So congratulations, Dawn. Let's get a round of
Oh, thank you.
for winning the scholarship. So we have 2 scholarship winners today. If you didn't win, that's okay, because we still have, I believe we still have 14 more to give away. So 14 more scholarships. The way you win, some of the scholarships are randomly selected. We have a drawing that we do, and others are based on participation. So you're still eligible. So we're still, 14 scholarships are up for grabs. And if you're participating in our ambassador program, in our Summit Ambassador program, whoever brings in the most friends and family members into the summit through this ambassador program will also win a scholarship. So again, we have 14 that are sponsored, and then 1 that is the Summit Ambassador winner. So there's still a lot. And then we have lots of other prizes we're going to be giving away throughout the summit. We have books, we have physical products. So you're going to be hearing a lot more about that in the next couple of days. So I'd like to conclude our day 2 for the live Q&A. And let me just see here if I can unmute you all. So if you want to say something, share some thoughts, feel free. But I wish you all a
Thank
wonderful
you
weekend.
very much.
Thank you so much, Dr. Rani.
Thank
This is
you.
absolutely
You're welcome.
fabulous.
The
You're
timing was
welcome.
great.
Thank you.
And invite your friends and family to join, even though we're into day 2, almost at day 3.
Thank
They can
you.
still join. They can still learn so much. So please, please, please
Thank-
invite them.
Thank you.
You're welcome. Okay, have a wonderful weekend. But actually, I'm going to be seeing you all tomorrow and Sunday. So, so it's a weekend, but enjoy your time, and then we'll meet again at 6 p.m. Eastern tomorrow. So, thank you. Take care,
Thank
everyone.
you.
Bye-bye. Bye.
Thank you very much.